rehabilitation, and that is probably it at the moment. And today he is going to talk about how to optimize how can community-based stroke rehabilitation be organized to be effective. And it would not be Thomas Platz if this is not related to systematic review evidence.
Thank you very much, Volker, for the nice introduction. Good morning, everybody. Welcome. That was the last talk was already quite demanding. Now let's have a look at stroke and how stroke rehabilitation in the community might work and what we can learn from systematic reviews. Looking into the systematic reviews of randomized controlled trials. There's no conflict of interest really on my side for this topic. I would like to have a brief look at the need for and the benefit from stroke rehabilitation more generally. Then what is community-based stroke rehabilitation, and then portraying the evidence from systematic reviews, especially for post-inpatient, community-based organizational forms of stroke rehabilitation, and draw some conclusions from that evidence. Now, the starting point is that neuroconditions are number one if it comes to causes of disability. And among those causes, neuroconditions, stroke, again, is the leading one. And these are high numbers, and the numbers had been increasing. So our societies should better be well prepared right now, but even more so in the future in many societies, as the burden of disability, the burden of stroke and other conditions is increasing. And we see that neurorehabilitation, including stroke rehabilitation, will become even more important than it is already nowadays. And then on the other side, stroke rehabilitation, like neurorehabilitation in other conditions, it's not an easy task. It's a rather complex task. It's a complex task to understand the situation of the individual stroke survivor. You have the different body functions. There are cognitive deficits, there are communication deficits, there are perceptual deficits, there are motor deficits, there are sensory deficits. There are emotional reactions to it. And there is a social situation that's highly individual. And the body functions, the impairments that lead to activity limitations, the combinations are different, the results are different, the causes for an activity limitation are different from patient to patient. And how that translates to fulfilling an individual's social role, again, is different depending on the circumstances and the preferences. So, and in each of these levels, we can actually provide interventions. We can look at the impairment level, you could look at the activity level, we can specifically support participation by adaptive interventions, assistive technology, etc., etc. So, but that is all very complex. So even in the individuum, it's complex, and that necessitates that the healthcare professionals are well educated. And as Derek Wade from Oxford is putting it, we do need the knowledge in the field for the neuroconditions. We do need rehabilitation, knowledge, experience, skills. And it has to be coming together. We need to understand the situation of an individual patient. We need to have a person-centered approach to addressing the needs, the rehabilitation needs coming as a group of people, a team, a multi-professional team, addressing the different problems in a proper way, coming up with a person-centered rehabilitation plan, work collaboratively, but not only within our institutions, but across the sectors. That's very demanding, isn't it? And that is where the benefit is actually generated. And we know that from inpatient stroke rehabilitation, where it had been tested by many randomized controlled trials. If you have this team, multidisciplinary team, working collectively, collaboratively, with special expertise and experience in stroke rehabilitation, then you are generating a benefit. If you have such a team, dedicated team providing stroke rehabilitation, you can reduce poor outcome. You can reduce dependency. You can reduce having to be institutionalized long term. So that's fantastic. Fantastic news. But life is not stopping at the first subacute rehabilitation phase, and there's still rehabilitation needs to be addressed after discharge. But now, what do we know about community-based rehabilitation? Is that working? And can we learn from the evidence which approaches, organizational approaches, might work best? Now, community-based rehabilitation, in the institution-based rehabilitation, inpatient rehabilitation is what might be our standard, our mental standard with this multidisciplinary team, as I introduced. Community-based rehabilitation is conceptually maybe considered broader, more looking into societal reintegration issues, more about inclusion, education, financial aspects, returning to work. But here today, I would like to concentrate on the part of the community-based rehabilitation that's still medical rehabilitation. And here in India, this is especially important because that is a different source of financing and funding, as opposed to the societal needs to be addressed. Okay, let's have a look at medical rehabilitation in the community. And that is work in progress that I do together with a PhD student, Stephanie Reichel, very enthusiastic physiotherapist who's doing her PhD on collaborative disciplinary teamwork in stroke and beyond. And what we do is we searched for systematic reviews of randomized controlled trials that look into organizational aspects of healthcare, medical rehabilitation in the community situation. We look into the evidence, we critically appraise the evidence, we look into the effectiveness, and from there, we try to learn what is the key message. What is the take-home message from the evidence for clinical practice? And in addition, identify, analyze knowledge gaps. If we do find signals that something is working, we also look into qualitative research. Why is it working? Why is it not working? But today I'm focusing on the quantitative research, and I'll do so. We have split it up, the community-based rehabilitation. We identified kind of pockets of evidence. There could be center-based outpatient rehabilitation services. There could be services in the community itself. And we distinguish home-based, really delivery at home, from community-based, where people might be seen as outpatients. And within the home-based, we again distinguish. We would differently look at family-based or telerehabilitation or case management approaches that do not deliver rehabilitation interventions, but facilitate such delivery. Okay, now the evidence I'd like to share is on early supported discharge, transitional care, which does not have to be early, stroke liaison worker, is that something that is helpful? Telerehabilitation, is that something that's helpful? Home-based rehabilitation, is there a benefit? Now let's start with early supported discharge. Early supported discharge, the idea is people are discharged home earlier if they receive the supported discharge. And the idea is early at home, provide service that achieves probably the same or even better outcome to patients and carer that is acceptable. And that's justifiable in terms of the resource use implications. Now, in this Cochrane review by Langhorne et al., only RCTs that provided such care had been included, and the primary interest was, can long-term dependency combined outcome with death, or can that be reduced? And then, very interestingly, so systematic reviews, meta-analysis have the advantage that they go into subgroup analysis, and we can get a more refined, a more specific information. And here, what we can learn is the subgroups where early supported discharge could be organized in 3 different ways. One is early people had been discharged home and might receive rehabilitation at home, but it was not specifically planned by a team. Not specifically planned. No ESD team. Next one, next level. Yes, there is a team that is coordinating, that is planning, coordinating, but it's not delivering. So people get their rehabilitation by therapists that are available in the community, but it's not the multidisciplinary team delivering. Or kind of highest level, early supported discharge, multidisciplinary team is planning and delivering at home. Okay, let's have a look. What is the data saying? Yes, okay, you can have such programs, and people had been discharged home compared to those who are not receiving their 6 days earlier, which is substantial. Okay, success in that respect. In addition to that, you would see that overall, yes, there is a benefit. So they did not worse, they had been discharged earlier, and they did not worse in terms of dependency and death, but rather better on average. But if you look on the right-hand side, on this diagram, you would see that you have now the 3 subgroups on top, delivery and planning. In the middle, only planning, no delivery. Below, discharge, rehabilitation without multidisciplinary team being involved. Now, the benefit that you see here is only if a multidisciplinary team had planned and delivered at home. If you did not have the combination, they did not have a benefit, not a higher benefit. Now, similarly, regarding the need to be institutionalized for care was lower in the early supported discharge group, very positive. Other aspects did not show a signal of a big difference. But no risk of readmission, early readmission with early supported discharge. Now, again, if you look on the right-hand side, you see the diagram for the outcome death. Again, the 3 levels. And now it's kind of scary to see in the upper 2 groups no effect on mortality. But in the lower group, early supported discharge, no planning by the team, no delivery by the team, a higher mortality. Ooh, so that is something that's kind of scary and needs to be taken into account. So effects later on were somewhat lower. What can we conclude? cost effects had not been that clear, at least no real differences being supported by the evidence. What we can say, what we can learn here is early supported discharge combined with team planning and delivery is supported, reduces dependency, and does not cause a risk for these subacute stroke survivors. And the data applies for people with moderate disability. Only those could have been included into the trial. Now, factors influencing the implementation of that is involving all stakeholders, clarify the referral path, have a qualified team, and have effective communication. Let's move on. Transitional care. It's similar. It could be early supported discharge, but does not have to be early supported discharge. But it's still this phase from hospital to the community and providing support in this phase. But it could be just structured telephone support. It could be outpatient support. It could be visits at home. Now, what had been the results looking into randomized controlled trials for transitional care? On the left side, you see mortality. And there is a benefit of transitional care. But if you look in subgroups, you see them on the left side. It's probably not very good to read, but on the top, you have a reduction of mortality, a significant effect, if there was a home visiting program. And early on, after 3 months, after 6 months, no longer significantly different. But with others, if there was not a team, but a single profession, there was such effects could not be substantiated. On the right-hand side, again, similarly, you would see, okay, now, basic activities of daily living overall, there was not a clear signal that this could be improved by transitional care, but in the upper part, you would see if there had been a home visiting program, so a dedicated rehabilitation professional going at home and looking what's up there and coming back and supporting, then you see an effect of activities of daily living, but not if there was an outpatient opportunity, not if there were just telephone calls, not if there was some management from the hospital, but nobody was going home. So interesting, isn't it? The results would show, yes, transitional care is beneficial. It might reduce mortality, and especially with home visiting programs. And again, with home visiting programs, we have seen a positive effect on basic activities of daily living. And that was even substantiated after a couple of months. While just having someone in the hospital, someone calling, or monoprofessional support did not do the trick. So it's not that easy to do the trick. This is what we again learn, similar from the early supported discharge work. Now, another approach could be that I do have what is called a stroke liaison worker. Stroke liaison worker is somebody, a case manager, is not delivering rehabilitation interventions, is providing education, counseling, is providing, facilitating, getting therapy, but it's not providing therapy. Now, overall, in these 16 trials, there was no clear signal that stroke liaison workers made a difference. But again, the subgroup analyses kick in. And specifically for stroke survivors who have moderate disability, they had a benefit if a stroke liaison worker was coming. They had a benefit that their disability was reduced by the intervention. And you see that on the right-hand side, now the upper part of the diagram, severe disability, lower part, no dependency with basic activities of daily living, and in the middle part, mild to moderate, and here is where the signal is, where stroke liaison workers helped to achieve a higher degree of dependency. Now, is that understandable? The authors think, yes, it's understandable. It may be that those who are already independent with daily living might need as much therapy and might not benefit anymore. And those who have severe disability can't cope at home if there is not a stable network to support them anyway. So take-home message, stroke survivors with mild to moderate disability benefit from such stroke liaison worker support who support but do not provide rehabilitation itself. Telerehabilitation. Various forms of telerehabilitation, telephone-based, internet, virtual reality, sensors, wearables. Now, compared in this Cochrane review, telerehabilitation services for stroke compared to in-person rehabilitation with a face-to-face situation. One comparison, and the second comparison compared to usual care. Compared to usual care. That could include nothing. So nothing or usual care compared to telerehabilitation or hospital-based intervention versus telerehabilitation. Now, 22 trials, almost 2,000 participants, compared to the face-to-face situation, that's in the lower part, no difference. Compared to usual care or nothing, no difference. And the trials that had been included looked into discharge support programs, upper limb training, lower limb mobility training, communication training being lumped together. So this is a bit kind of disappointing. It's okay to see it's not worse than the hospital base. It's not worse than face-to-face. But then you would like to see, compared to usual care, including nothing, you would like to see a benefit, but it didn't show up. Cost effectiveness, not that clear. Safety, no problem in these trials. So, but the lack of superiority compared to usual care, that really needs close attention. Why is that? So one might conclude, yes, it's a possibility, especially if people cannot have face-to-face rehabilitation, as is the case in many situations. Now, what about therapists visiting patients at home, home-based rehabilitation? And here a systematic review that looks into home-based rehabilitation, both in the subacute and chronic phase. That's nice. So we are leaving, this transitional phase and have now randomized controlled trials that could be included even when people had been, stroke survivors had the stroke a long time ago. And again, the the comparison made to hospital-based rehabilitation and a comparison being made to usual care. But now the scenario is different. You again have the situation that the data would say it's not worse than hospital-based rehabilitation if rehabilitation is provided at home. But now we have a significant difference compared to usual care. That's interesting, isn't it? If therapist is going home, they generate this difference, what we did not see with the telerehabilitation. You see that on the top, no difference to hospital-based, bottom, bigger impact compared to usual care. Again, further subgroup analysis of interest. If this home-based rehabilitation addressed upper limb activities impairment, the effect was not substantiated. If it addressed mobility, balance, or endurance, yes, there is a signal. So it seemed from this data that for mobility, balance, and endurance, it's easier to achieve a benefit by home-based rehabilitation. Okay, you could say home-based rehabilitation was comparable to hospital-based rehabilitation, while at the same time now being superior to usual care, including no rehabilitation, especially for activities of daily living and for mobility. So it is effective for some goals, might not be for all goals. Let's summarize and conclude with this marvelous collection of knowledge in beautiful city of Italy in Firenze. Now, we know, and that's pretty sure, that this multidisciplinary, collaborative, inpatient rehabilitation post-stroke is effective, reducing disability, avoiding the need for long-term institutionalized care. That's perfect. Now, what about what I addressed with the systematic reviews today, the perspective for people being discharged, people living in the community? We have seen that it's possible to discharge people earlier and provide early supported discharge if they have moderate disability, and it's beneficial to do so, and it's not a risk to do so on average, if they are supported in terms of planning and delivery of rehabilitation by an experienced team. If they are just discharged with no team being available, there's even a health risk. We have seen higher mortality rate. Transitional care in general, again, there was a signal that the multidisciplinary team seems to play a pivotal role. And when that was available, activities of daily living improved and mortality was reduced. If you just have somebody who is working as a stroke liaison worker, which is fine, which, however, does not provide rehabilitation intervention, that might be suitable for people with moderate disability. And so information provision, networking, addressing needs, not by rehabilitation itself, but by networking and facilitating such services, that is beneficial and reduces dependency with these moderately affected people. Home-based rehabilitation by experienced therapists and teams where there is goal orientation and a person-centered approach, the typical neurorehabilitation approach that we consider so important. They have assessment, planning, goals, and interventions selected that are individual and meaningful to support goal attainment. That's positive and can support people achieving their goals. Telerehabilitation, in this Cochrane review, the evidence has not been that clear, but still, I think it needs to be considered as an option when service access is otherwise not possible. And with that, I would like to conclude. I'm very happy to take comments and questions if time allows, Mr. President.
Thomas, thank you very, very much indeed for this very clear review. Unfortunately, I think we're running out of time significantly. So if you have burning questions to Thomas, just contact him in the break.